Hello, I'm Thomas Wickman, and this is a presentation accompanying the chapter on the rationale for surgical interventions in movement disorders. The chapter was co-authored by Dr. Malin DeLong and me. We are both in the Department of Neurology at the School of Medicine at Emory University. Let me introduce this topic with a brief historical overview. Ablative approaches for movement disorders were empirically developed in the 1930s, targeting the basal ganglia or the motor thalamus for treatment of tremor or involuntary movements. At least since the 1950s, it was known that electrical stimulation of the motor thalamus could suppress tremor, but this technique was used then primarily as an intraoperative testing strategy to identify the optimal site for lesioning. Implantable stimulation devices were not available at that time. Functional surgery for movement disorders declined in the 1960s following the introduction of effective medical treatment for movement disorders, especially levodopa treatment for Parkinsonism. However, the popularity of surgical options increased again in the 1990s due to several important developments. One of them was that physicians and patients realized the limitations of medical therapy. Further, the functional organization of the basal ganglia had been worked out at the time, including the discovery of a new surgical target for treating Parkinsonism, the subthalamic nucleus. The benefits of highly targeted pallidotomy became also more appreciated at that time, specifically through the work of Dr. Leitinen's re-examination of Lexell's posteroventral pallidotomy, which was first practiced in the 1950s and 60s. Further, engineering advances had occurred that made implantable stimulation devices available, making deep brain stimulation treatment possible. These were then used by Dr. Alim Benabid in Grenoble to develop high-frequency deep brain stimulation techniques for treatment of movement disorders, first applied to the thalamus for treatment of tremor, later to the subthalamic nucleus for the treatment of Parkinson's disease. In current clinical practice, most clinicians use deep brain stimulation to surgically treat movement disorders because of the effectiveness, the versatility, and the relatively low invasiveness of this technique. However, ablative techniques are staging a comeback with the recent introduction of focused ultrasound lesioning. This very brief historical look shows that the surgical interventions were largely empirically developed. When we talk about the rationale for surgical treatment of movement disorders, we are attempting to understand why and how surgery works in these conditions and how to use it more rationally in the future. In this talk, we will initially then consider the anatomical realities which present a key rationale for surgical treatment of movement disorders, and then talk about some of the clinical features and medical treatment options, as well as the pathophysiology of the two movement disorders that are frequently treated with surgical interventions, Parkinson's disease and dystonia. The written chapter also discusses the treatment of essential tremor, which will not be discussed here because of time constraints. The lack of medical treatment or severe side effects of medications and the effectiveness of surgical treatment are major reasons to offer surgery to our patients. Finally, we will talk about the physiological effects and future extensions of surgical approaches to movement disorders. These may become part of the rationale for surgical interventions in movement disorder cases in the future. Let us then first turn to the anatomical foundation for surgical treatment of movement disorders. The general anatomy of the brain connections that are relevant for movement disorders is shown in this slide and the figure. The basal ganglia, shown here in the green rectangle, are considered to be key structures for the development of most movement disorders. They are a collection of nuclei that receive cortical and thalamic inputs, process them, and then project their output to the thalamus and brainstem, and ultimately to the cerebral cortex. All excitatory connections in this diagram and subsequent figures are shown as gray arrows, while inhibitory connections are shown as black arrows. The two entry points for cortical and thalamic inputs to the basal ganglia are the striatum and the subthalamic nucleus. Basal ganglia output, on the other hand, arises from the internal palatal segment, which is GPI in this diagram, and the substantia nigra pars reticulata, SNR. The projections from these nuclei are inhibitory and directed at thalamic and brainstem targets. The thalamic recipients project then back to the same areas that gave rise to the input in a family of segregated reentrant circuits, which I will discuss shortly. The subthalamic nucleus, STN in this diagram, also provides some basal ganglia output, in this case excitatory, to the pons and the pedunculopontine nucleus. In addition to the basal ganglia thalamocortical circuitry, this diagram also shows the cerebello-thalamocortical circuitry. The cerebellum is shown in the blue rectangle here. The last few years have seen a flurry of studies of the relative roles of these two pathways, which is the basal ganglia thalamocortical pathway and the cerebello-thalamocortical pathway. For motor control and movement disorders, as well as their possible interactions. This is an important topic to which we will return later. Coming back to the basal ganglia circuitry, it is important to realize that the intrinsic and extrinsic basal ganglia projections are highly topographic. In fact, the basal ganglia and associated areas in the cerebral cortex and thalamus can be divided into anatomically separate circuits serving motor, oculomotor, associative, or limbic functions. This figure shows several of these circuits, demonstrating that the areas that are involved in different functions differ between the various structures. These are segregated circuits. Dysfunction within a given circuit is associated with specific clinical signs and symptoms. Some of the resulting conditions are listed underneath the diagram. For example, the motor circuit on the left is involved in the pathophysiology of movement disorders, such as Parkinson's disease or dystonia, while the limbic circuit, all the way on the right, is involved in psychiatric conditions, such as obsessive-compulsive disorder. The fact that these functional circuits are spatially segregated is a highly important rationale for functional surgical interventions, because it allows surgeons to make focal lesions to achieve the desired effects, limiting them to the relevant functional domain while sparing others. As mentioned earlier, the motor circuit is particularly relevant for the pathophysiology of Parkinson's disease and other movement disorders, so let's look at this circuit in more detail. It originates from motor areas of the frontal cortex, which project to the putamen, which is the motor part of the striatum, as well as to motor-related components of the subthalamic nucleus. These nuclei project then to motor areas in the internal pallidum, GPI, and the substantia nigra pars reticulata, SNR. From there, motor circuit projections reach the ventral motor thalamus, abbreviated here as BGMT for basal ganglia recipient motor thalamus, as well as the intralaminar nuclei of the thalamus, particularly the central median nucleus, CM. Basal ganglia output also reaches the pedunculopontine nucleus, PPN. The internal connections between the striatum and the basal ganglia output nuclei are organized into the so-called direct and indirect pathways. The direct pathway is a monosynaptic GABAergic inhibitory connection that links the striatum to the basal ganglia output nuclei. In contrast, the indirect pathway is a more complex system. It passes through the external globus pallidus, the GPE, and the subthalamic nucleus. Authors often also discuss another pathway, which is the hyperdirect pathway, This describes the cortico-subthalamic connection, which has relatively direct access through the subthalamic nucleus to the basal ganglia output structures. Functionally, activation of the direct pathway leads to inhibition of the basal ganglia output structures. This is a monosynaptic inhibitory connection. The reduction of the inhibitory basal ganglia output then may lead to disinhibition of related thalamocortical neurons and a facilitation of movement. In contrast, activation of the indirect or the hyperdirect pathway would have the opposite effects because of the polarity of the connections that are involved. So activation of these pathways would actually act eventually to reduce movement. Basal ganglia activity is regulated by several neuromodulators. It is worth discussing specifically the role of dopamine, one of these modulators. This is a neurotransmitter that is heavily involved in disease states. Dopamine release in the striatum regulates the function of both the direct and indirect pathways via different dopamine receptors. It modulates the transmission at corticostriatal synapses, facilitating transmission at cortical inputs onto the direct pathway via dopamine D1 receptors, and inhibiting transmission at cortical inputs onto the indirect pathway via D2 receptors. Given the polarity of connections involved, the combination of both actions will end up reducing basal ganglia output and thereby facilitating movement as a result of dopamine release in the striatum. In addition to this role in the regulation of the overall amount of movement, dopamine is also known to have a very prominent role in reinforcement learning, which will not be discussed in any detail here. As a whole, the motor circuit may be involved in a variety of functions, including the selection of actions, the initiation of movement, as well as the control of the overall amount of movement and its speed. This combination is called vigor, as well as the formation of habits. Of these, the control of movement vigor may be particularly important in terms of movement disorders. We're now returning to the interactions between the basal ganglia and the cerebellum. It was thought for a long time that the basal ganglia thalamocortical circuits and the cerebello-thalamocortical pathways were separate systems, functioning in isolation from one another. This view has now changed, based in large part on anatomical studies by Peter Strick's group, as well as imaging work. The two systems, the basal ganglia thalamocortical system and the cerebello-thalamocortical systems, are now considered as components of an integrated motor network. The anatomical studies identified links between the two circuit systems as well. The basal ganglia cerebellar route originates in the subthalamic nucleus, as is shown here, and reaches the cerebellum by way of the pontine nuclei, abbreviated PN in this diagram. In return, cerebellar output from the deep cerebellar nuclei, abbreviated DN, reaches the basal ganglia by way of the thalamus. Given these connections, disturbances in one system will affect the function of the other. At the present time, the evidence is compelling that the cerebellum plays a role in several movement disorders, including Parkinson's disease, tremor, and dystonia. While in current practice, the basal ganglia remain the major target of surgical treatments of movement disorders such as Parkinson's disease or dystonia, knowing the cerebellar involvement in the pathophysiology of these conditions may be important for the future development of surgical targets. Let's now consider the clinical features, medical treatment options, and the pathophysiology of some of the major movement disorders. Starting with Parkinson's disease, many of the clinical motor signs of this condition arise from the degeneration of dopaminergic neurons in the substantia nigra pars compacta. This is part of a more general neurodegenerative process that involves many other neuron groups as well. Death of the dopaminergic neurons leads to loss of striatal dopamine and the development of Parkinsonism, a group of characteristic movement disturbances including bradykinesia, slowness of movement, tremor at rest, and muscular rigidity. Given the biochemical deficits, dopamine replacement has been the primary treatment of Parkinson's disease for many years. This is highly effective against bradykinesia and rigidity, but levodopa treatment is less effective for many patients who suffer from tremor. It is also important to know that long-term use of levodopa is often complicated by the development of motor fluctuations, such as the sudden wearing off of drug effects or the development of involuntary movements called dyskinesias. The primary reason to offer surgery to a Parkinsonian patient is the presence of treatment-resistant tremor or the presence of significant unmanageable drug-induced dyskinesias or motor fluctuations. It is important to realize that not all aspects of Parkinson's disease respond equally well to surgery, specifically the development of levodopa unresponsive features such as speech problems, gait and balance disturbances, cognitive issues, or autonomic dysfunction limit the overall benefits of surgical interventions. So what happens when dopamine is lost in the striatum? Our knowledge in this area is largely based on studies in dopamine-depleted animals. Early electrophysiological and metabolic studies led to the development of the so-called rate model of basal ganglia function, which is depicted in this figure and described in the text of this slide. In the rate model, Parkinsonism is seen as a consequence of static changes in activity throughout the basal ganglia network. In this diagram, the width of the gray and black arrows indicates the amount of activity in the corresponding pathway. As mentioned, dopamine is thought to have opposing effects on the direct and indirect pathways mediated by the different dopamine receptors. In the rate model, striatal dopamine loss leads therefore to opposing effects on the direct and indirect pathways as well. Dopamine loss leads to greater activation of the indirect pathway, resulting in inhibition of external palatal neurons and subsequent disinhibition of SDN neurons and greater driving of internal palatal cells. On the other hand, the activity of the direct pathway is reduced by dopamine depletion, resulting in reduced inhibition of palatal neurons. Together, these changes result in increased GPI output, which then in turn leads to greater inhibition of thalamocortical activity and reduced movement. The rate model is supported by recording studies in dopamine-depleted animals and by the fact that lesions of the overactive pallidum and the subthalamic nucleus have anti-Parkinsonian effects, as one would expect from this model. Both nuclei are said to be overactive in Parkinsonism, so lesioning should be anti-Parkinsonian. Recent optogenetic studies in rodents have also supported this concept. However, the rate model is not supported by the fact that surgical interventions that target the ventral thalamus do not have clear motor effects in patients. Further, the rate model can be turned around to say that if increased basal ganglia output reduces movement, reduced palatal output should result in involuntary movement. This is clearly not the case, as the experience with clinically performed paladotomies has shown. All in all, the rate model has therefore historically been important as a conceptual aid for our understanding of movement disorders and the effects of surgery, but it is likely to be too simplistic. Instead, changes in firing patterns of neurons throughout the basal ganglia thalamocortical circuitry are considered to be highly relevant for Parkinsonism. Some of these changes are seen in these recordings of single neuron activities from normal and Parkinsonian animals. The single neuron recordings show changes such as increased bursting activities and oscillations in the 13 to 30 Hertz range. That is the so-called beta band oscillatory activity. These recordings also show abnormal synchrony of the activity of neighboring neurons. In recordings of local field potentials, which are signals that reflect more widespread and synchronized network activities, increased coupling of oscillatory activities between cortex and basal ganglia has been described. Within given signals from either cortex or subcortical areas, increased coupling between the phase of beta band oscillations and the amplitude of concomitant gamma band oscillations was also found. This linkage is called phase amplitude coupling, or PAC. Finally, investigators have found that isolated gamma band oscillations, which are oscillations at frequencies above 30 Hz, accompany drug-induced dyskinesias, while low-frequency oscillations are seen during tremor. It is important to realize that it is not clear whether any of these changes or the previously described firing rate changes are truly causal for Parkinsonism. They are strongly associated with Parkinsonism, but may not cause it necessarily. Moving on to another movement disorder that is commonly treated with surgery, that is dystonia. Dystonia is characterized by abnormal postures and involuntary movements which are thought to result from co-contraction of agonist and antagonist muscles as well as excessive activation of muscles. Dystonia can occur as a generalized or a focal disorder. In children, generalized forms are generally more common and are often genetic in origin, such as generalized torsion dystonia. In adults, focal dystonia is more common. For example, cervical dystonia, blepharospasm, spasmodic dysphonia, and writer's cramp. The available systemic medications for dystonia are of very limited usefulness because they're often not effective enough or have significant side effects. An interesting option for the treatment of focal dystonias are injections of botulinum toxin into the affected muscles. This can be highly effective. Surgery is used for treatment of dystonia in cases that are poorly responsive to medical or toxin treatment. If surgery is an option for a given patient, it is important to treat the disease at an early stage to limit the development of contractures, to facilitate motor development, and to maintain a high quality of life. Dystonia is not a single disease and may be a component of many conditions. As such, the pathophysiology of dystonia is very heterogeneous, involving the basal ganglia, the cerebellum, and the cerebral cortex, either alone or in combination. We will consider these in turn, as they either are or could become targets for surgical treatment of dystonia. So starting with the basal ganglia involvement. There are several examples of dystonia arising from basal ganglia abnormalities. Perhaps the best example in this category is the case of dopamine responsive dystonia, often abbreviated DRD. This is a genetic condition that is due to altered striatal dopamine release. Another example is dystonia due to the use of dopamine receptor antagonists. These drugs can produce dystonia, presumably by acting in the basal ganglia. Both examples are clear examples of a basal ganglia origin of dystonia. Another argument in favor of a basal ganglia origin of dystonia is the finding that many dystonias are effectively treated by surgical interventions that target the basal ganglia output in the internal pallidum or the subthalamic nucleus. Finally, basal ganglia involvement is demonstrated by the fact that the activity patterns of neurons in the basal ganglia output nuclei is abnormal in individuals with dystonia, demonstrating, as in the case of Parkinsonism, both non-oscillatory and oscillatory abnormalities as listed on this slide. I will not go through the individual points here. There's also emerging evidence that dystonia can arise from abnormalities in the cerebellum. Some of the evidence for this comes from animal studies, for instance, studies of rapid onset dystonia Parkinsonism, a genetic condition in humans whose symptoms could be mimicked by local disruption of the function of the sodium-potassium ATPase in the cerebellum. The enzyme sodium-potassium ATPase is abnormal in rapid onset dystonia Parkinsonism. Other evidence comes from MRI tractography in patients with generalized dystonia. These studies identified cerebellar abnormalities in cerebellothalamic tracts in these patients. Interestingly, the anatomical interactions between the cerebellum and the basal ganglia may be important for at least some forms of dystonia, therefore involving both to some extent. An example of this is shown in the drawings on the right side, which is an illustration from a study in an animal model of dystonia Parkinsonism. So panel A shows a normal awake mouse with simultaneous recordings of both the cerebellar nuclei and the striatum. The cerebellar nuclei recordings are in black, the striatal recordings are in red. Inhibition of the sodium-potassium ATPase in the cerebellum in panel B results in dystonic posturing of the animal, which is pointed to by the arrow in panel B. Continued recordings in the cerebellar nuclei and the striatum shows gross firing abnormalities in both structures, at least possibly due to the functional interactions between the cerebellum and the striatum mediated via the thalamus. What you can see here are bursts in both the cerebellar nuclei, the CN neurons, and in the striatum. Subsequent studies showed, and this is very important, that focal thalamic lesions disrupting the pathway from the cerebellum to the striatum relieve the dystonia. Finally, a few words about the evidence supporting the involvement of the cerebral cortex in dystonia. There are essentially two lines of evidence for this. One is that positron emission tomography or MRI studies in patients with dystonia have shown widespread changes of activity in cortical motor areas, including altered somatotopic maps and abnormal cortical activation patterns in visuospatial tasks. Other evidence comes from electrophysiological studies which demonstrated abnormal somatotopy and increased cortical excitability, as well as abnormally low levels of EEG desynchronization during the initiation of movement. In addition, studies with transcranial magnetic stimulation, TMS, showed increased cortical plasticity and reduced cortical inhibition. While the changes described here show that the cerebral cortex is affected by dystonia, it is not clear whether the described changes can occur in isolation or whether they always require additional subcortical abnormalities to be present. In the last few minutes of this lecture, I will talk about the surgical approaches to movement disorders more specifically, outlining their physiological effects as well as potential future extensions of these approaches, which may become part of the rationale for using these procedures in the future. There are a variety of surgical interventions for treatment of Parkinson's disease, as is listed in this slides. The procedures include ablative and simulation procedures, although lesioning is now rarely used. The subthalamic nucleus and the internal pallidum are both excellent treatment options. DBS of the thalamus is used only in tremor-predominant cases. DBS of the pedunculopontine nucleus has been used to treat gait and balance problems, but remains experimental. Then in dystonia, ablative and DBS treatments are usually directed at the motor portion of the internal pallidum. DBS targeting the subthalamic nucleus is also effective. In essential tremor patients, ablative or DBS therapy targets almost exclusively the cerebellar receiving portions of the ventral motor thalamus. In some cases, DBS of the posterior-dorsal subthalamic area can also be used, presumably affecting the cerebellar pathways in this condition en route to the thalamic targets. It remains unclear how the different surgical interventions for movement disorders work. However, there are a few observations which may be relevant, which are presented on this slide along with the inferences one can draw from them. One point to remember is that lesioning eliminates the output from the targeted area, while DBS stimulation primarily activates fibers, both orthodromically and antidromically, leading to excitatory and inhibitory effects. At least in the case of DBS, then, these effects can be very complex, considering the different types of fibers that emerge from or travel through the stimulated area. The figure on the right side demonstrates this for stimulation of the subthalamic nucleus. The stimulation is shown here as a series of blue circles. As shown, the stimulation will affect a large number of relevant fiber tracts, including afferents and efferents of the SDN, palladothalamic fibers, as well as the corticosubthalamic tract and even parts of the internal capsule. It is far from clear which of these is actually relevant for the effects of the stimulation. Another key observation is that both lesioning and stimulation of motor portions of GPI or SDN ameliorate both hypo and hyperkinetic symptoms. In other words, neither the exact mode of the intervention nor the exact specifics of the movement disorder appear to matter greatly to the effects of the surgical interventions. However, what does matter is accurate targeting of the motor circuit. Finally, it's worth mentioning that the time course of the responses to lesioning or to DBS differs between symptoms, as is mentioned in some detail here, and I'm not going to go through these details specifically. So a few general conclusions or inferences can be drawn from these observations. One is that it is unlikely that surgical interventions truly correct the abnormal brain activities that specifically cause movement disorders. More likely, these interventions allow relatively intact portions of the motor system to compensate more effectively. Another very general inference is that short latency responses may result from direct alteration of network activity. One would see those in Parkinsonism specifically and other tremor disorders, while the delayed effects, such as those seen in dystonia, may require neuroplasticity to take place. A new technique that may influence the rationale for surgical interventions for movement disorders in the future is the introduction of on-demand stimulation approaches. The idea behind this is shown in the figure on the right. The top panel shows the current clinical practice, so without on-demand stimulation, in which stimulation is applied constantly without concern for the severity of the patient's current clinical state. This works well in general, but could nevertheless be suboptimal because it may induce unnecessary side effects and, of course, because it tends to deplete the stimulator battery more quickly than absolutely necessary. These issues then could be dealt with by using self-adjusting on-demand stimulators, which would measure symptom severities to adapt the stimulation to the patient's needs. This is shown in panels B and C. So panel B shows a variant, a relatively simple on-demand regime that has been tried with success. The stimulation is triggered based on internally recorded signals that reflect the severity of the disease, such as the power of beta band oscillations in the SDN or the cerebral cortex. Every time the beta band power passes a certain threshold, deep brain stimulation is triggered and, of course, switched off again when the beta band power falls below the threshold. More nuanced stimulation may be attainable with continuous adjustments of the strength of the stimulation depending on the amplitude of the measured variable. That is shown in panel C. Potential control signals for Parkinsonism that have been tried for on-demand stimulation purposes are the power of beta band oscillations in the subthalamic nucleus or cortex, the duration of episodes of increased beta band power, or the use of signals from external sensors such as accelerometers, which may help to identify the presence of tremor specifically. Alternatively, one could also use the emergency of gamma band peaks to identify times when it would be best to switch off the stimulator. As you may remember, gamma band peaks are specifically seen with the emergence of treatment-induced dyskinesias. Closed-loop DBS has become a clinical possibility because of the availability of new generations of stimulators that have built-in amplifiers, digitizers, and digital processing units, obviating the need for external devices. In general, closed-loop DBS would be most easily implemented in conditions in which the stimulation leads to rapid responses, such as Parkinson's disease or tremor. Slowly responding diseases, such as dystonia, will not be as easy to deal with. A topic that regularly enters discussions about the use of surgery for movement disorders is the question when such interventions should be used. This has been studied in some detail with regard to the treatment of Parkinsonism. The current practice is to initiate DBS treatment about 10 years after the diagnosis is being made, at a time when the disease becomes more difficult to manage and the side effects of levodopa treatment have become problematic. The motivation for early surgical treatment is that it may prevent or ameliorate the disruptive drug-induced side effects and therefore may improve the overall quality of life. In addition, some animal experiments suggested that surgery may be neuroprotective in pre-symptomatic cases of Parkinsonism. It is important to realize that this has not been confirmed in patients with the disease. One of the major studies that has looked at surgery early in the course of Parkinson's disease was the Early STIM study, a European study in which DBS was initiated at an average of 7 years after diagnosis. This study was very successful, showing that early DBS was superior to best medical treatment in terms of motor disability, levodopa-induced motor complications, and the quality of life. The quality of life was measured with an instrument called the PDQ-39, a scale where low scores indicate better quality of life. The figure on the right comes from that study, comparing PDQ-39 scores in patients with neurostimulation or medical therapy. The stimulation had a significant positive effect on the quality of life in these patients and with an acceptable side effect profile. A more recent study used DBS even earlier, within 4 years of diagnosis, at a time when most patients still feel well on the medications. The authors showed the feasibility of such a study with a suggestion that the progression of tremor may be reduced. However, several patients sustained significant adverse effects so that the overall benefits of very early surgery for Parkinson's disease are not clear. In addition, very early interventions such as this come with a risk of inadvertent inclusion of cases of atypical Parkinsonism, because we do not have a reliable biomarker that would separate typical from atypical cases. As we come to the end of this talk, let me briefly summarize the major points that were made. There are 3 major motivations for the use of surgical treatment of movement disorders. One is that the functional anatomy of the motor system, and specifically that of the basal ganglia thalamocortical circuit, is very conducive to the use of functional surgery. The segregation of motor from non-motor circuits allows surgery to be highly focused, reaching brain regions that are involved in motor disturbances but avoiding those that are not. Another argument in favor of functional surgery is that it is empirically simply highly effective for diverse disorders and symptoms. As discussed, this may be further enhanced through the use of closed-loop DBS approaches in the future. Further studies of the pathophysiology of movement disorders is absolutely essential to this effort, as it may help to develop the necessary control signals for closed-loop systems. The rationale for the use of surgery is also that medical treatment is often not sufficient or has unacceptable side effects, so that surgery becomes the preferable treatment option. We also discussed the targets and potential mechanisms of action of these interventions. While precise anatomical targeting is essential, it seems that these interventions do not specifically reverse the pathophysiology of movement disorders, but instead allow the relatively healthy components of the motor system to function more normally. An important point to emphasize is that movement disorders do not exclusively arise from the basal ganglia or related brain areas, but may involve or even originate from other areas, such as the cerebellum or the brainstem. Exploration of these regions for surgical treatments is an obvious area of future development.